Hello, anatomy colleagues. This is Dr. Alsup, and in this video, we will be exploring integumentary system basics. So specifically, after this video, we should be able to differentiate between the layers of the integumentary system, as well as the associated deep fascia. We will differentiate these based on location as well as anatomical characteristics, and then we'll apply this knowledge to some common clinical situations. But before we get into that detail, it is important to define the integumentary system. What even is it? It has a long, kind of complicated name. Well, this is an organ system composed of skin and usually superficial fascia, sometimes referred to as the hypodermis or the subcutaneous tissue. You'll see these other terms often. Skin is hugely important clinically. First and foremost, it is visible and it is accessible. And it's usually the first thing considered in most physical exams. So just looking at a person's skin can give an indication of issues with deeper structures. Is there swelling? Or is there changes in the color of the skin, as in bruising or a change in typical color that can indicate something like blood not carrying enough oxygen from the lungs? Also, damage to the skin is visible in terms of lacerations, burns, etc. Additionally, skin incisions are important considerations in surgeries, as you might imagine. So, considering where you should place an incision to get best access, but also minimize healing as well as scarring. So, let's talk about this skin. It is actually composed of two layers. The more superficial and visible layer is the epidermis. So when you are looking at skin, you are looking at the epidermis. And this is actually an epithelial layer, which makes sense as it covers the external surface of the body. There are some living cells in its deepest parts, but the majority of the cells in the epidermis are dead, keratinized, meaning filled with keratin to allow toughness and water resistance. It's also importantly this layer is mostly avascular, meaning it does not have a blood supply, which also makes sense as most of these cells are dead. So if you have a cut in the skin and it doesn't bleed, you know you have just an epidermal cut. Deep to the epidermis is the dermis, and this is the largest layer of the skin, and it is quite a bit more complex. The dermis is highly vascular, and it is composed of connective tissue, not epithelium. We say this layer is more complex because it contains many other important structures. Of particular importance to clinicians are afferent nerve endings. These nerve endings will message sensation back to the central nervous system. So signals involving pain, very importantly, temperature, pressure, and others. And why this could be so important, think about being able to pinpoint on the skin where you have no feeling or say tingling in the skin or paresthesia. That can lead you to understand which nerve or part of the central nervous system may have an issue. We'll actually spend a good amount of time on this concept in the neuro portion of the curriculum. So this is just another example of the skin giving you clinical clues for issues with deeper, less visible portions of the body. Also present in the dermis are sudoriferous or sweat glands, sebaceous, aka oil glands or oily glands. Hair follicles are also going to be located in the dermis, as well as associated musculature called erector pili muscles that will stand up in situations of excitement or fear. You will see the abbreviation MM here. That stands for muscles, plural. And we'll use this type of abbreviation consistently. So just one M would equal a muscle, A would be arteries, veins would be V, and then nerves would be indicated by an N. And if we had two of those, that's going to be the plural. So to quickly review, the epidermis is superficial, the dermis is larger, more complex, and deeper. Both of these layers together equal skin. All right, let's go even deeper. Let's actually move away from the skin and talk about the closely related fascia. The wonderful world of fascia. You will hear us talk about fascia all year and in all parts of the curriculum because it is literally everywhere and you will certainly encounter it in the laboratory. Fascia is grossly visible connective tissue. And gross here doesn't mean ew, gross. It means visible to the naked eye. So just deep to the dermis is a variable layer of loose areolar tissue with some other connective tissue for structure called superficial fascia. And this varies widely between individuals and in different parts of the body. So think about the amount of um, subcutaneous tissue you have, say, on the back of your hand as compared to the anterior abdomen or the inner thigh region. So not only does it differ between individuals, it differs in different parts of the body. There are also similar structures to the dermis that reside in the superficial fascia, such as sweat glands, superficial blood vessels, and afferent nerves. Also importantly, the superficial fascia is going to be part of the integumentary system, so it is considered a component of it. So superficial fascia is going to be part of the integumentary system, but deep fascia is not. Um, but I did want to mention it here because we are going to encounter it in the laboratory. Deep fascia can be located anywhere in the body, not just directly deep to the dermis like the superficial fascia. Deep fascia is going to be composed of dense, typically irregular connective tissue. And it surrounds structures like muscles or groups of muscles, organs, and neurovasculature. So located in all parts of the body, not just directly deep to the skin. And before we finish, I want to return to the dermis because it often gets overlooked for the more visible epidermis, but it is also extremely clinically important. Because it is composed of connective tissue, it provides the tone of the skin. And the collagen fibers that are making up that connective tissue of the dermis, they're arranged in a very typical pattern. And these are called tension lines. There are going to be different maps that kind of outline where these are located. Sometimes you hear tension lines referred to as cleavage lines or Langer lines. They're all the same thing. And as you continue within your education, particularly if you move into surgery, you will begin to develop an understanding of the organization of these lines because this helps to determine the type of incision that should be made for maximal closure and the least amount of scarring. If you go vertically through these tension lines, that causes gaping of a wound, whereas if you can kind of follow parallel to a Langer line, that will allow for better healing. Skin laceration repair, specifically sutures, typically involve all layers of the integumentary system, so the epidermis, the dermis, and sometimes the superficial fascia, but not always. Alignment and repair of an incision is mainly afforded by this dermal layer due to that strength that we mentioned and the typical arrangement of the collagen fibers. So we're not going to get into the nitty-gritty details of how to do a suture specifically, but there's often little more to incisions and sutures than meets the eye. We wanted to introduce this here and much more to come in your clinical settings throughout your education. All right, excellent. We have reached the summary slide with highlights of some of the highest yield concepts from this learning objective. Return to this for review, and as always, please reach out with any questions. Have a great rest of your day.